So, hi friends, back with another session here. In this video, let us understand the concepts of Dermatitis Herpetiformis, EBA, and then we'll be dealing with the intro part of Psoriasis. So, under this dermatitis, it's written that what the immunofluorescence it shows granular IgA at dermo-epidermal junction. So before that, let us understand what are we speaking of. We started with vesicobullous blisters, right? We started with blisters where this vesicle or the bullous can be in the epidermis, which we have already discussed, and that is known as intra epidermal blisters. And you have a blister which are below the epidermis, so we call it as subepidermal blisters. Under the subepidermal blisters, which we have already spoke two of them, and the third one is dermatitis herpetiformis. So let me read the points written here under this dermatitis herpetiformis. So it's written that under the direct immunofluorescence of a patient that shows a granular IgA at dermo-epidermal junction, and it's also written that clinical features dermatitis herpetiformis, no relation with herpes simplex virus, and cutaneous manifestation of gluten sensitivity. So it's also written that IgA against transglutaminase. So let us understand what's happening here. So if you look at this, right, so let us look into the picture, and that shows you the pathophysiology of what's happening regarding the celiac disease. So if you look at this is the picture, and that shows the intestine. This is intestine, and you can understand that you have an enzyme known as, you can look at this, transglutaminase. This is an enzyme transglutaminase. Now what's happening in this dermatitis herpetiformis? You have an antibodies which are acting against this transglutaminase. Why the antibodies are acting against the transglutaminase? Because these guys are sensitive. That means their body, a few persons, the body thinks that the transglutaminase is a foreign antigen. So our body thinks that, these guys' bodies think that the transglutaminase is an antigen that has come from outside, so the antibody starts acting against this transglutaminase, right? So that's all we have to understand regarding these aspects. And if you look at this, and you have another here, so if you look at this is a gluten, right? The gluten normally you get it in the wheat. The moment you eat that, the gluten comes inside, and now these patients, right? So these patients who are sensitive to this gluten, they also, that means the body also produces antibodies against this gluten. So right now you have an antibodies against this transglutaminase, right? You even have an antibodies, right? And you even have an antibodies against this gluten. And remember that the antibodies which are produced in these dermatitis herpetiformis will be IgA antibodies. So if you look at these are IgA antibodies. So the IgA antibodies which are produced against the transglutaminase, they not only react to the transglutaminase, they also react to the junction. They also react to the dermo-epidermal junction of the skin. This is a skin, right? You can look at this is a skin. So the antibodies IgA, they react to the dermo-epidermal junction. So that's all we have to understand regarding these points, and that's all it's written that. So the antibodies now they go and attack the dermoepidermal junction, and you can look at this, you have a blister here, right? You can look at these and these blisters, right? And this is known as a dermatitis herpetiformis, right? So let us understand, let us read the points once again. So it's written that under this dermatitis herpetiformis, it has got a no relation with herpes simplex virus. If there is no relation with herpes simplex virus, and why do you expect it has herpetiformis? So let us look into the lesions. So this is how the dermatitis herpetiformis looks, and if you observe carefully, it looks like a lesions of herpes simplex virus. So that's the reason we gave the name herpetiformis. So that's all it's written here regarding this dermatitis herpetiformis that has got no relation with herpes simplex virus. And if you look at the next point written here, it's written that a cutaneous manifestation of gluten. It's a cutaneous manifestation of gluten sensitivity. 30% patients have, the 30% of the celiac disease, they have this gluten sensitivity. And if you look at the next point written here, it's written that the antibodies are against the transglutaminase, which we have already seen that in the pathophysiology. So that these antibodies, they go and act on the dermoepidermal junction, right? Dermoepidermal junction. So in right now, you are in a state of understanding what's happening in the dermatitis herpetiformis. But let us look into the structure where that is a direct immunofluorescence picture, and this is a direct immunofluorescence picture, and that shows the antibodies are seen at this dermo. This is a dermis, this is epidermis. So you have an antibody seen at this point. This is known as a dermoepidermal junction, right? So that's all we have to understand regarding these points, and these are the granular type. So this is known as a granular IgA at dermoepidermal junction, right? So you can look at this. These are the granular type. So that's all it's written, that a granular IgA at dermoepidermal junction. So that's all we have to understand regarding these points. So let us look into these aspects. So it's written that herpetiformis lesions, grouped, dermatitis, itchy, we have papules, vesicles, no bullae, and it's also written that site seen in extensor, knee, elbow and back. So let us understand them. So let us look at this once again and let us read the things written here. So it's written that it's like an herpetiform lesions. That means these are grouped. So it looks like an herpes simplex virus disease. So that's the reason we call it as herpetiformis lesions. And if you look at these are itchy. Severely it itches. And if you look at these apart, right, you can look at these are papules. And what do you mean by papules? Papules are nothing but the size is less than 0.5 centimeters. So say let me take one of these out and draw it here. So this is how it looks, right? And it is less than 0.5 centimeters. So that's all it's written here. And it's also written that no bullae, right? We know that bullae is nothing but it's a lesion where there is an accumulation of fluid, and now it is more than 0.5 centimeters, and these bullae are not there, and where only the vesicles are present. What do you mean by vesicles? Vesicles are nothing but it's a fluid content. It is less than 0.5 centimeters. So let me take one of this out. So in draw it here, and you can look at these are small. It has got a vesicle here, it has got a fluid, and that is less than 0.5 centimeters. So that's all you have to understand, the meaning of papules, vesicles, no bullae, and remember that it severely itches, right? So where do you find these? You get it in the extensor sites, that is knee, elbows and back. So knee, elbows and back, you have sites. So that's all we have to understand, guys, regarding these points. So let's go to the next point. So the next thing written here, it's written that if you take the biopsy, right, if you take the biopsy in such persons, so you have something known as a neutrophilic microabscess, right? You have a neutrophilic microabscess at the tip of dermal papillae, and it's also written that a granular IgA deposit at the tip of dermal papillae. So let us understand them, guys. So what I'm gonna do now, so you know that these are the lesions, right? You got a different lesions of, right, you got a different lesions. So when I take biopsy out, and when I look under the microscope, and you can find a neutrophilic. So let us understand, let us see them, let us take this small part, let us take the biopsy out, and let us see under this microscope, and this is how it looks, right? So this is epidermis, and this is dermis. This is epidermis, this is dermis, and this becomes the dermal papillae, right? You got a dermal, these are the dermal papillae, right? So these are the epidermal ridges, right? So if you look at these points written here, it's written that we have a neutrophils in the cleft. So you can look at this neutrophil in the cleft and the papillae. You can look at this is the dermis. This is the dermis, and this is epidermis, and you have a neutrophils present here. So that's all it's written, that in the biopsy, neutrophils, right, neutrophilic microabscess are seen at the tip of dermal papillae. This is a tip of dermal papillae. So this is how it looks, and that's all it's written here regarding the biopsy. So let's go to the next one. The next point written here, whenever you look under this direct immunofluorescence, you have a granular IgA deposits at the tip of dermal papillae, which we have already discussed, but let us look into that once again. So you can look at this. These are the, this is a dermis, this is epidermis, and this becomes the dermal papillae, right? You have a papillae here. These are the dermal papillae. These are dermal papillae. And if you observe here, these deposits are in a granular type. So these are known as a granular IgA deposits. These are granular IgA deposits, and these are deposited at the tip of dermal papillae. So that's all we have to understand regarding these points. That is a granular IgA deposits at the tip of dermal papillae. So let us understand the treatment for this. The treatment will be the treatment of choice. What's the treatment of choice for this dermatitis herpetiformis? And the treatment is dapsone. Treatment is dapsone. It's also written that a diagnostic of dermatitis herpetiformis, and it's also written that a gluten-free diet, avoid iodine. So let us understand them, guys. So what is the mechanism of action of dapsone? The mechanism of action of dapsone, it inhibits the dihydrofolate folic acid synthesis, right? It inhibits. So now there is no production for the cells. So what happens? It reduces. It acts as an anti-inflammatory, right? It acts as an anti-inflammatory. And how does it act as anti-inflammatory? Because it blocks the production of dihydrofolic acid that is needed for the formation of cells. And remember that if the moment you give a dapsone, right? The moment you give dapsone, and if that cures, if the dapsone cures this herpetiformis, and remember that, and this is the diagnostic, right? And this is a diagnosis, this is diagnosis of dermatitis herpetiformis. So that's all we have to understand. The moment you give dapsone, and if the person cures, and this is the diagnosis of dermatitis herpetiformis. And you know that we have an antibodies against the gluten, and give a gluten-free diet, and avoid iodine, right? So that's all we have to understand, guys, regarding these aspects. So let's go to the next points. The next will be, yes, if you look at this, the next points here, we have something known as epidermolysis bullae equisita, right? So let us understand them. What is it trying to tell us regarding these points? So yes, so let me read the points written here. It's written that IgG against the type 4 collagen, and it's also written that clinical features similar to bullous pemphigoids, right? And it's also written that biopsy similar to bullous pemphigoids, and we have a direct immunofluorescence, right? So let us understand them, guys. So what's happening in this epidermolysis bullous equisita? So it's written that we have an IgG antibodies against the type 4 collagen. So let us understand what it is trying to tell us. For that, I have to take the structure or the junction. So if this is the epidermis, epidermis has got a layers like stratum corneum, it has got a layer like lucidum, it has got a granulosa, it has got a spinosa, and you have got a basal layer, right? And this is what, this is a dermis. So let me take this junction of this is known as epidermodermal junction. So when I take the junction between the epidermis and the dermis, and this is how it looks, right? And this is the junction, the what you are observing, this becomes the basal cell, right? Basal keratocytes. And here down you have a dermis. In between that we have these structures which we have already discussed in detail. But the point we have to understand here is that has gotten different regions, and now we have something known as a type 7, we have an type 7 collagen here, and you have a type 4 collagen here. If you observe carefully here, we have a type 4 collagen present in the densa, right? It is present in the densa. Yes. So if this, the diagram, we have a type 4 collagen present here and type 7 collagen present here. Now what's happening in this epidermolysis bullosa equisita, that is EBA? Now the antibodies come and act on this type 4 collagens, right? They go and act on this type 4 collagen. So when it acts on the type 4 collagen and it disturbs the type 4 collagen, and you have a gap, this is damaged nerve. So you have a gap between the epidermis and the dermis, and this is a subepidermal bulla. So that's all we have to understand regarding these points, guys. So we have an IgG against the type 7 collagen. So that's the meaning of IgG against the type 7 collagen. And this has got all the similar features like bullous pemphigoids, which we have already discussed, like blisters, large blisters and all that. And which we have already discussed in these bullous pemphigoids, where there is a linear deposits of IgG and C3 at the junction of at the dermoepidermal junction. And why do you have at the dermoepidermal junction? Because the pathophysiology of epidermolysis bullosa equisita, now these are acting against the type 7 collagen. So that's all we have to understand, guys. And if you look at this, we have a salt split immunofluorescence. So what do you mean by salt split immunofluorescence? Salt split in the immunofluorescence in the sense whenever you do immunofluorescence, now they gets divided. So at the top you have an epidermis and down you have dermis. Now if the antibodies are present at the bottom, at the floor, and this is a case of EBA, that is epidermolysis bullosa acquisita, and if the antibodies are present at the top, and this is known as bullous pemphigoid. So that's all we have to understand regarding these points, and in detail I have already explained in regarding the salt split immunofluorescence, but just understand these are the important points, guys, regarding this epidermolysis bullosa acquisita. So let's go with the next points. So let's look into the next points. So the next thing written here, yes. So you can look at this. This is how the split skin looks. Whenever you do immunofluorescence, this is how you can look into the direct immunofluorescence. So if you have an antibodies at the floor, and that means that this is a case of epidermolysis bullosa acquisita. Suppose if you have an antibodies at this aspect, right, at the roof, then this is a case of pemphigus. This is a case of bullae pemphigus, right? So bullosa pemphigus. So that's all you have to understand regarding these points, and that's all it's written here. So let's go with the next points, guys. Next we have something known as a target lesions. So let me read the points first and let us understand the concepts. So under this target lesions, it's written that the lesions look like a target, right? The lesions look like a target, and it's also written that we have a purple and it is white, red, and let us understand them, guys. So if you look at this is how the target lesions looks, right? And if you observe carefully the points written here, these lesions look like a target. So if you observe here in the center, right, in the center you have a purple one. So you can look at this has got a white, it has got a purple, it has got a red. So let us see how this target lesions looks. So you can look at this another picture where you can appreciate more clearly here, where you can look at this. In the center you have a purple, right? This is purple, and this is surrounded by white, and it has got a red. So you have a purple here, you have a white and the red, and this looks like a target, so we call it as target lesions, right? And these target lesions, what it is, let us see the causes of these target lesions. So the causes are, it is seen in herpes simplex virus, and it is seen more in herpes simplex virus, and then comes the mycoplasma, right? And then comes the mycoplasma, then comes other infections, then comes the drugs. So that's all we have to understand regarding these points, guys. The causes, the first will be the herpes simplex virus, then comes the mycoplasma, then comes the other infection, then comes the drugs. So in these conditions you can look at the target lesion. So this is how it looks, and these target lesions, they are more common on the acral areas like hands, feet, and the face. So that's all we have to understand, guys, regarding these target lesions, how they look, and these are look. So let's go with the next points. So that's all regarding this sub-epidermal bullae. So now let us understand the next topic, and that will be papillosquamous disease. So under this it's written that a solid raised squamous lesions, seals on raised lesions, scales on raised lesions, and it's also written that psoriasis affects 1 to 3% of populations. It is a chronic condition that relapse and remitting skin disease. So let us understand them, guys. So what do you mean by papilla? Papilla is nothing but these are papules. And what do you mean by squamous? Squamous is nothing but these are characterized by scales. So we have a disease that is characterized by scales, and we have papules. So if you look at this, right, and this hand contains scales, right? So this is known as squamous, that means characterized by scales. And they also have papule, right? They also have papules. So that's all we have to understand regarding these points. And if you look at the next point written here, it's written that these are solid raised squamous lesions, scales on raised lesions. So let us understand them. To understand this in detail, let us take one of the disease, and that will be psoriasis. So under this, it's written that it affects 1 to 3% of population. So out of 100%, how much it is affect? Just affects 1 to 3% of populations. So it is a chronic condition, right? And that relapse and remits. And what do you mean by relapsing? Relapsing is nothing but a coming back or returning back. What is remitting? You have an improvement. So you have improvement, right? Again you have a disease, you have improvement, disease. So this type of nature is known as relapsing and remitting skin disease. So relapsing is returning back, you get the disease again. Remitting in the sense again it improves. But now let us understand the etiopathogenesis under the psoriasis. So it's written that the genetic factors positive, external precipitating factors, and it's also written that cytokine imbalance. Like we have an interleukin 12 and we have interleukin 23, and we have a T helper cells 1, right? Tumor necrosis factor alpha, T helper 17, all this. So let us understand them, guys. So let's go with the first thing here. So why do you have in psoriasis and what's happening here? So you have two causes. It can be a genetic factors that can lead to psoriasis. You can have external precipitating factors. So what happens if you have a genetic factors or external precipitating factors? We'll be dealing in detail, but right now just understand, because of genetic factors, because of external precipitating factors, now there will be a cytokine imbalance. Now, what do you mean by cytokine imbalance? Cytokine imbalance in the sense, normally our body has gotten cytokine cells. Now say example, if there is excess or increase in interleukin 12 or interleukin 23, right? And this interleukin 12 activates the T helper cells, right? It activates the T helper cells, and these T helper cells in turn activate or they release tumor necrosis factor alpha, right? So the first thing is because of cytokine imbalance, there is interleukin 12 increased, and that activates the T helper cells, and this release tumor necrosis factor alpha, and this tumor necrosis factor leads to epidermal proliferation and inflammation. And let us see, if there is interleukin 23 increased, that activates the T helper cell 17, and this T helper 17 releases interleukin 17, and this interleukin 17 leads to epidermal proliferation and inflammation. So because of these interleukin 12, interleukin 23, because of these cytokines imbalance, because of excess excess production of these interleukins, ultimately it leads to epidermal proliferation and inflammation. And these epidermal proliferation and the inflammation leads to, or that is responsible for psoriasis. So if you look at this is because of epidermal proliferation, it is because of inflammation. You have got this type of natures, and this is known as psoriasis. So that's all we have to understand regarding this etiopathogenesis. So let's go to the next one's written here. So it's written that the biologics used in psoriasis. So let us understand the treatment here itself, since it is written here. Now we have a drug that blocks the interleukin 12, right, and the interleukin 23. So let us look into the drug which blocks interleukin 12 and interleukin 23, and the drug is ustekinumab, right? And this drug, right, US, remember this US blocks two things, interleukin 12, interleukin 23. And we have other drugs known as infliximab, adalimumab, right, etanercept. These are the drugs which blocks the tumor necrosis factor alpha. So suppose if this block, right, these are the monoclonal antibodies, so they act and they block this interleukin 12 and interleukin 23. So whenever these are blocked, you don't have a further steps. So no production of epidermal or no epidermal hyperproliferation and no inflammation. So if you're going to use this drug like infliximab or adalimumab and etanercept, they block the tumor necrosis factor alpha. So ultimately there is no production of epidermal, or if there is no epidermal hyperproliferation and inflammation. So that's all we have to understand, guys, regarding these concepts. So let's go with the next things. So the next thing written here, that's the etiopathogenesis. So let us understand how the genetics influence the psoriasis. So let us understand the first thing written here. It's written that HLA-CW6, right? And under this it's written that strongest association with psoriasis, familial and early onset and severe disease. So let us understand them, guys. So what's happening? Suppose if a person has HLA-CW6, right? And these patients, they have got a strong association with psoriasis. These patients, they have got a strong association. That means if they have this, and they have the psoriasis. And remember that this is a familial type, and these patients have got an early onset and severe disease. They have got an early onset and the severe disease if a patient has HLA-CW6. Now if a patient has HLA-B27, now these HLA-B27s, these are associated with seronegative arthropathies. That means if a patient who have an HLA-B27, they not only have the psoriasis but can also have an other problem also. So we have a mnemonic here known as PAIR. What is P? P for psoriasis. What is A? A for ankylosing spondylitis. What is I? I for inflammatory bowel disease. What is R? R for reactive ritus, right? So that is a ritus. So that's all you have to understand. The pair, the seronegative, right? The seronegative. What are those? PAIR. P for psoriasis, A for ankylosing spondylitis, I for inflammatory bowel disease, and R for reactive, that is ritus. So that's all we have to understand the points under this HLA-B27. So HLA-B27, HLA-CW6, they are associated with psoriasis, right? These are the genetic causes. So let us look into the other part of genetic causes. So what is the relative risk? If you look at this genetic population, it is of 1 to 3. They have got, these patients have 1 to 3%. They have got a risk here regarding the psoriasis. Say example, if a father has, if one of the family member has, and the baby or he has a 7% chances he can have a psoriasis. If both the parents have psoriasis, then now the percentage is 49%. The baby can have 49% chances that he can have psoriasis. So that's all we have to understand regarding a relative risk. That's all you have to understand regarding this HLA-CW6 and HLA-B27. So now it's time to understand the external factors, how these external factors can influence the psoriasis. So let me read the points written here. So it's written that regarding these infections, you have a group A beta hemolytic streptococcus, so sore throat, and we have something known as a guttate psoriasis, right? So let us understand them, guys. So a patient who have a group A beta hemolytic streptococcus, right? The patients who have a group A beta hemolytic streptococcus, they reside in the throat, so you have a strep throat. And these patients, right, these patients who are affected with group A beta hemolytic streptococcus can have a psoriasis, and now this type of psoriasis is known as guttate psoriasis, right? It is known as guttate psoriasis. So if you look at this, what do you mean by guttate? Guttates are nothing but their presence as small lesions, right, over the upper trunk and proximal extremity. So if you look at this, so this is how the guttate psoriasis looks, right? This is how the guttate psoriasis looks, and this guttate psoriasis looks, they present as a small lesions, right? You can look at this, they are present as a lesions, and they are present over the trunk, right, and the proximal extremities. So that's all we have to understand regarding these external factors. The infection can also cause psoriasis. So not all the infections, even the drugs can also cause psoriasis. So we have the mnemonic, and it's written that LIBAS, libas, but my mnemonic BAILS, BAILS. And what is B? B for beta blockers. So beta blockers can cause psoriasis, And what is A? A for anti-malarial. And which anti-malarial drugs like chloroquine can also cause this this type that psoriasis, right? And these are the external factors. What is I? I for ibuprofen, right? This ibuprofen can also cause psoriasis. What is L? L for lithium. L for lithium. S for salicylates. L for lithium. S for salicylates. So that's all we have to understand regarding these points. So these beta blockers, anti-malarial like chloroquine, like ibuprofen, right, and L for lithium, S for salicylates, these can cause psoriasis. So that's all we have to understand regarding these external factors. Even they can influence, right? So they can aggravate or they can cause, in the sense even they have chances of we can have a chances of getting that, right? So that's all we have to understand regarding this. The moment you take these drugs, so that can influence the patient can have psoriasis. So these are the external factors. First is regarding the infections. The second is drugs. So let's go to the next one. The next we have a trauma. So trauma can also can also lead to it is also an external factor. So under this we have a phenomenon. And what do you mean by this phenomenon? And this is known as Kober's phenomenon. And what do you mean by Kober's phenomenon, which I have already discussed? Say example, if this is hand, right? And if a patient has a psoriasis here, now when I hurt him, right, regarding this trauma, suppose if there is a trauma at this aspect, and this patient have a lesions similar to psoriasis, and this type of phenomenon is known as Kober's phenomenon. So just understand, Kober's phenomenon is a phenomenon because of trauma. After the trauma, he get the same lesions which he has already, right? So that's all you have to understand regarding these points. So the same lesions, that is isomorphism. So let's go to the next things. Even the smoking can also cause psoriasis, can also has an effect, right? Even that also has effect on psoriasis. The mental stress, right, and alcohol can also leads to psoriasis. So that's all we have to understand regarding the external factors which influence the psoriasis. So let's go to the next one's written here. So it's written that there is epidermal hyperproliferation. Under this it's written a normal turnover time is 28 days. In psoriasis, turnover time 3 to 5 days. Normal cell cycle time is 311 hours and 311 hours, and the psoriasis, and this is 36 hours. So let us understand them, guys. So we're dealing about the epidermal hyperproliferation, so which we have already discussed. A normal epidermis, that means for every 28 days our cells, the epidermis forms, a new epidermis forms. But what's happening in the psoriasis? In the psoriasis there is hyperproliferation of epidermis. Because of hyperproliferation of epidermis, now the time taken for the shedding of epidermis, for the formation of epidermis, it is just of 3 to 5 days. Within 3 to 5 days you have a new epidermis. So that's all we have to understand regarding this epidermal hyperproliferation. The normal turnover, the meaning of turnover in the sense the shedding of epidermis and forming a new one. And the next thing written here, what is the normal cell cycle, right? The normal cell cycle is 311 hours, but in the psoriasis the normal cell cycle is 36 hours. You can look at this, it has reduced to so much from 311 hours to 36 hours, so that it has got an excess of proliferation, hyperproliferation, the short duration of time. So what are the clinical features of psoriasis? So in this session we'll be dealing about the first one, and that is what it's also known as plague, right? Plague psoriasis, a chronic plague, or we also call it as a classic plague, and we call it as psoriasis vulgaris. So let us understand them, guys, under these clinical features. So we got on various type of clinical features. So the first thing is plague or chronic plague. So if you look at this, so let us see how the plague looks, right? So if you look at this is how the psoriasis, and this is the type of this is known as a plague psoriasis, right? Plague psoriasis, or known as chronic plague, or we call it as classic plague, right? And we have also known as psoriasis vulgaris. So that's all we have to understand regarding these points. And the next point written here, it is a well-defined erythematous plagues with a silvery white layered scales, mainly on the extensor, and it is symmetrical. So let us look into the same diagram here. If you look at this, this has gotten well defined, right? It has gotten well defined here. You can clearly demarcate it's a normal skin and it's a psoriatic skin. So it's a well defined, and remember that it is an erythematous plaques. You can look at the red one, these are erythematous plaques, and this has gotten silver white layered scales. So you can look at this, these are the silver, right? These are the silvery white scales, right? So that's all we have to understand, guys, and these are mainly seen on extensor, and that too symmetrical, that is two hands are affected mostly in the extensor aspects. So that's all we have to understand regarding these points. So let's go with the next one. The next we have something known as grattage. So what do you mean by grattage? That means we're gonna scrape now, right? We're gonna remove this, we're gonna scrape this out, and let us see how it looks. So whenever you scrape that, you have something known as a candle wax scales or a candle wax phenomenon, and it's also written that a bright red shiny membranes known as Berkeley's membrane, and it's also written that pinpoint bleeding starts, and that is Auspate sign. So let us understand them, guys. So let's go with the first thing, that is, now let us take scrapings, right? Let me take scrapings. So let me take the scrapings. So let me scrape this out and let us look, right? And whenever you scrape this out, you can get as fine scales, and these fine scales are called candle wax scales. So this is how the candle wax looks. So these scales looks like in candle wax. So we call it as candle wax scales, or also called as candle wax phenomenon. And if you look at the next point written here, it's written that we have a bright red shiny membrane, and that membrane is known as Berkeley's membrane. So if you look at this is a psoriasis, and this has gotten a bright, right? It has got a bright red shiny membrane, and this bright red shiny membrane, this is known as a Berkeley's membrane, right? This is known as a Berkeley's membrane. So that's all we have to understand regarding these points. And if you look at the next point written here, it's written that there is something known as a pinpoint bleeding, right? Pinpoint bleeding starts, and this is known as what? Auspate sign. So let us understand this. Now if you look at this, you're gonna scrape this psoriasis now. So when I scrape this out, and you can look at this, this is a before and this is after scraping. You can look at this, this is you have a pinpoint bleeding starts, right? And this pinpoint bleeding starts after the scraping. This sign is known as Auspate sign. Auspate sign. So that's all we have to understand regarding these points. So let's go to the next thing. The next we have a phenomenon, the same thing, cognerization phenomenon. So which I have already discussed. What's that? It's a phenomenon if the same lesions are seen at the non-psoriatic area after the trauma. So that's all we have to understand, guys. And in this we have a rings here, right? In this plague type we have a ring known as Voronov's rings. So let us understand what are Voronov's rings, and let me read the points written here. It's written that hypopigmentation rings around the psoriasis, and also called as those are called as Voronov's rings, and usually indicate resolving psoriasis. So let us understand them, guys. So this is half the Voronov's rings looks, and if you observe carefully here, if you take one lesion out and you can look at this, you have an hypopigmentation. So this is an hypopigmentation which is surrounding this is a psoriatic part, right? You have the red one is psoriasis, and surrounding that is an hypopigmentation. So the hypopigmented ring around the psoriasis, we call it as Voronov's ring. And what does this indicate? It usually indicate resolving psoriasis. That means psoriasis is resolving. So that's all we have to understand regarding the part 1 of psoriasis, right? So part 1 of psoriasis, and let us meet in the next session. Thank you.